Hi, this is Dr. Phil Smith back again with part 4 of my 8-part segment on solving the MedRec problem, deconstructing medication reconciliation. Today I'm going to talk about physician-provider factors that impact our ability to accurately do medication reconciliation. Again, I include a slide about me for those who are interested. But as I talk about these 30 problems in this 8-part series, I want you to refer to this fishbone or Ishikawa diagram that shows all these factors that come together to make it very difficult in our pursuit of an accurate and true medication list. But today we're going to focus, and I've zoomed in on physician and provider factors, of which you can see on this diagram to the left, as well as the 2 prior segments that I have on part 2 and part 3 around disease and condition factors and patient factors. So the first physician factor is making an assumption that a list of medications in front of me is actually true and accurate. I may not realize that that list in my medication record, be it printed or electronic, may no longer be accurate for multiple factors. The patient may have had an encounter with another doctor. They may have gone to a minute clinic. They may have run out of medication or stopped medication for whatever reason. And so failing to get an updated medication history because I assume that the medication list in my medical record is updated is an error that can lead to confusion and invalid medication reconciliation. The second thing is not to understand that multiple physicians are involved, and some physicians do medication reconciliation better than others. And so just because someone recently did it doesn't mean it's true and accurate. So I need to find out by myself and take a minute to review with the patient or whatever data I have available what the current list of medications should be, and if something's been discontinued, what was the thinking or the conditions that caused it to be discontinued or modified. Third, I may have issues myself with training with the tools that are used for both obtaining and documenting a current medication and reviewing that, as well as the tools to perform medication reconciliation. One of those problems is not understanding the function of Cancel RX. And Cancel RX is a newer function offered by SureScripts. SureScripts is the provider that in the United States provides the gateway that physicians are allowed to do electronic prescribing from many electronic health systems and through standalone applications on their devices and mobile devices. And the purpose of Cancel RX is to send a definitive communication to the pharmacies that there is an intent to cancel an existing medication that the pharmacists may have on the record due to prior e-prescribing. And some doctors just assume that if they don't refill a medication, that the pharmacy is going to magically know that this medication has been discontinued. And the pharmacist, meanwhile, may be thinking that the refills have merely run out. They will try to do the patient a favor, contact the physician office to get a refill. The staff may be helpful in shortcutting that and saying, yes, that's true, I see the patient still on that, and not go to the prior note and see that the medication has actually been discontinued, and we end up with an endless cycle of confusion. So Cancel RX is a great function that's been added to our e-prescribing tools to send a definitive message into that database through SureScripts to allow a definitive cancellation of a medication. But again, even some electronic medical records haven't fully adapted this feature within the workflow. Another factor are complex medication. The example I like to use is there's a chemotherapy drug that's used for brain cancers that has to be prescribed in a very specific dose based on a daily dose based on the weight of a patient. And when you do those calculations, let's say the patient ends up needing 35 milligrams a day of a medication. Well, this creates problems if the medication only has a 10 milligram tablet and a 35 milligram tablet. So in order to get 45 milligrams, in electronic prescribing, I have to prescribe both prescriptions. So I have to send an electronic prescription for a 10 milligram tablet, and I have to send a prescription for a 25 milligram tablet. Now, the confusion can occur at multiple points in that that may be seen as a duplicated medication. Some people who don't understand that the total dose is 35 milligrams may say, oh, that 10 milligram prescription is no longer valid. It's been changed to a 25 milligram dose, or vice versa, reduced from 25 to a 10 milligram dose, and they actually may accidentally cancel one of those two prescriptions. Or the patient may think it's a duplicate, or they may accidentally take, knowing they have to take two tablets, may take two of one bottle of pills, with some days getting a 50 milligram dose and some days getting a 20 milligram dose. So to do this accurately, the doctor has to indicate on each tablet that the 10 milligram is taken with a 25 milligram to get a 35 milligram dose, and then they have to manually enter the 25 milligram has to take with a 10 milligram dose in order to get 35 milligram dose. Then they also have to include the weight of the patient plus the target dose of the patient, so the pharmacist is totally in the loop. So this causes a lot of opportunities for errors, both in errors of omission from leaving critical information off, and errors of commission because of the system canceling a duplicate order, or because of a nurse or pharmacist seeing it as a duplicate order and accidentally canceling one or the other. Finally, we have beliefs and attitudes. Doctors sometimes don't know the medications that other people are prescribed, and so they feel uncomfortable reconciling the medications, and that can create confusion, especially if there's medications on the profile that are listed as generic and they're unfamiliar, or accidentally there may be med listed as a generic name and a trade name, which can lead to duplications. So if your belief or attitude is that medication reconciliation is not my job, and I'm going to leave that to someone else to do, you may be missing an opportunity to review and update a current list of medications, and that can lead to errors that occur when you're not available and someone else may be covering for you, or an error that the staff may make on your behalf. And so all of these factors play into major errors that occur with medication reconciliation and in getting a true and accurate list of medications. So again, this is just part of the many factors that feed into errors that medication reconciliation has. And in the next one, I'll be discussing ones that occur at the pharmacy level. Again, if you haven't already downloaded the free copy of my ebook, here's the URL. You can get it. See you next time.